All right, we'll go ahead and get started. I'm Dr. Tom Herzog. I want to thank everyone for coming out on a Sunday morning. That's a high tribute. So thank you. Sunday morning of SGO. I hope everyone's enjoying your meeting. We're going to be talking about expanding the arsenal, innovative strategies to treat platinum-resistant ovarian cancer. These are our objectives. As you can see, we want to look at the recent advancements in ovarian cancer, talk about some of the things that are going on in the competitive landscape, understand the efficacy and treatment outcomes with some of the traditional therapies, but also some of the new therapies that we're going to talk about, which is great. And then hopefully we're going to have a dialogue with you, the audience. So we look forward to interacting together. I think that's important, So certainly we need to make more advances. I think, unfortunately, patients in whom platinum is no longer an option still remain a very large unmet medical need. And so there's, I think, great need to have this dialogue and to also do the studies, right? So without the studies and without your enrollment, we don't have the data to speak about, and we also don't have the new drugs to offer our patients. So thank you for all that you do. This is our agenda. I'm not going to read the whole agenda to you. You can see there, but you can also see that I'm on the stage with three good friends and colleagues who are amazing people, and I'm going to have them introduce themselves at this time. Why don't we start? Lindsay, why don't we start with you?
Sure. My name is Lindsay Wilmot. I'm a GYN oncologist in Phoenix, Arizona.
Hello, everyone. My name is Nicoletta Colombo. I'm also a gynecologic oncologist from Milan, Italy.
Hi, everybody. My name is Alex Olawai. I'm a GYN oncologist from the University of Pittsburgh.
Awesome. These are our disclosures. Leave it up for 1 second. Everyone usually clicks through it so fast you can't even see who you're disclosing. All right. This is a CME program. We should have a table tent there where you can do the pretest. Pretest only takes a few minutes, and it's very helpful to us. So if you would please do that, and also will help you obtain your CME, because we can do a quick pretest, post-test, and then you're all set. So we very much want to have that. I'll go over some things at the end, too, in terms of how you obtain your CME. But we again, very much appreciate you being here. It's important that we disclose our financial relationships, obviously, for CME, as we've done, and it's important that you now take the survey, if you would. That'd be very helpful. So you just scan the QR code on your table. And that's the code there. I'll leave it up. If anyone doesn't have one on their table, do that. Okay. All right. So that brings us to our first speaker, Dr. Holloway from the University of Pittsburgh. He's going to give us an understanding of the competitive landscape for patients in whom platinum is no longer an option. Alex?
Thank you, Tom. Good morning, everybody. It's so nice to have you here very early on Sunday morning in the beautiful city of Washington, Seattle. So this roadmap of ovarian cancer therapy is one that is always exciting to see, and the most important thing about the roadmap is how it started being very narrow, and it's getting wider and wider. And if you notice there, about 2014 is when the roadmap actually had a massive change. And since then, there has been no stopping, the widening of the roadmap. On the top part of that roadmap is the treatment scenario where a lot of drugs have been approved for therapy, and below those drugs that have been approved for maintenance therapy. And, second-line platinum therapy in patients with ovarian cancer previously treated with cisplatin was where all this started, because cisplatin was the only platinum agent back then. And this old slide is like to show you that it was recognized earlier on back then that platinum-free interval basically influenced the overall response rate to platinum drugs. And as you can see here, you go from platinum-free interval of 5 to 12 months with overall response rate of 27% to when the patient recurs or the disease progresses after 24 months, the response rate, as you can see there, is nearly 60%. So the PFI, platinum-free interval, does matter. Now, it became necessary to actually group patients just because we need to have a definition to it. So the initial 3 groups that were created were like those people where the disease came back within 6 months of initial exposure to platinum agents, between 6 and 12 months, and more than 12 months. And we still use this, but the more popular definition is when, we just use the first group, less than 6 months, and then we combine the remaining 2 groups, so 6 months and beyond, and call them platinum sensitive. And so, as shown from the first, definition slide, it's not that the platinum agents no longer would work at all once there has been exposure to platinum. It's just that their chances of working are much less. And as you can see here, you often have to combine the platinum agent with something else in order to make it work. And the response that you get, the progression-free survival, if you look at the last column there, is somewhere between 3 months and 9 months. And generally speaking, the more lines of therapy ovary cancer is exposed to, the less the chances of response. That is, regardless of what type of therapy you're talking about. So as you can see, from first recurrence without a PFS of 10 months or more, to by the time the patient is being exposed to the 6th line of therapy, you barely get 4 months of progression-free survival. And so then the categorical definitions of platinum-related therapy is what you see on the right side of the slide. So we divide generally this definition to the first time the patient is being treated and then subsequent therapy. So platinum-free interval is, we have the refractory group when the patient progresses on the primary platinum therapy. The primary platinum-resistant group is when the patient progresses or the disease progresses within 6 months of the first therapy, and acquired or secondary platinum-resistant when the patient progresses within 6 months or during the subsequent platinum therapy, so basically after 2nd line. Now, it's important here to remember or keep in your minds that the regulatory agencies actually do not care about primary platinum resistance or secondary platinum resistance. To them, platinum resistance is platinum resistance. Mm-hmm. And the first major trial to look at what we do with patients with platinum-resistant ovary cancer is the Aurelia trial, which basically looked at pegylated liposomal doxorubicin, paclitaxel, and topotecan. And on the control arm, these were all agents that were approved and on the market for standard utilization. And then on the experimental arm of the trial, they combined these drugs with bevacizumab. As you can see from the progression-free survival curves there, the trial met its primary endpoint, which was progression-free survival, and the overall survival had a trend towards significance. It did not, it was not significant, but it was a very, very impressive trial. And when the trial was analyzed by chemotherapy cohort, and again, just know that this is a subsection analysis, so, but it's important, right? Because we use this to actually counsel patients in clinic and determine what we're going to use in the platinum-resistant ovarian cancer space. So you can see there that the delta of benefit looked best for weekly paclitaxel, 10 months versus 3.9 months, followed by topotecan, which you see to the right of the curve of the slide, about 5.8 months versus 2.1 months, and then pegylated liposomal doxorubicin, 5.4 months versus 3.5 months. And the overall response rate follows the same, follow the curves. The best group was the paclitaxel group with overall response rate of 51.7 months 51.7% in the bevacizumab arm, all the way down to 22.8% in topotecan with bevacizumab. And then come the new era of the antibody drug conjugates. As you can see right here, I like this diagram because it just makes it simple. It's a combination of an antibody targeted against an antigen that is expressed either exclusively or mostly on cancer cells with a linker that links that antibody to a payload. The payload is actually a chemotherapy, which is being targeted towards the cancer here and delivered into the cancer space, hopefully sparing the normal cells because the linker is stable in the systemic circulation. And here is a graphical representation of what happens when you use antibody drug conjugates. As you can see here, the antibody drug conjugates get internalized by the cancer cells, and once it gets into the lysosomes, the linker is clipped or digested, and then the drugs get released into the cancer cells and cause the death of the cancer cells. And the first drug that was approved in ovarian cancer was the mavacamten soravtansine drug, which for the ease of my teeth, I'm going to call MERV. The MAV drug, it's an antibody drug conjugate targeted towards folate receptor alpha or folate receptor 1, as some people prefer to call it. MAV is internalized via endocytosis, and it's degraded within the lysosomes. It releases the payload, which is some drug called DM4. It's a maytansinoid that is very poisonous to microtubules and therefore leads to cell death when it's released inside the cancer cells. And this SORAYA trial is a trial of approximately 105 patients, phase 2 trial, and demonstrated a very impressive overall, response rate of 34%, and in the investigator-assessed, cohort. And if you look at the median duration of response, which is the bottom of that left side, it was actually 11.7 months by blinded investigator central review. And therefore, and also, overall response rate after 1 to 2 lines was, of course, better than after 3 lines. It was 35% versus 30%. And, the one surprising thing in SORAYA was, every time you want to treat a patient that has been exposed to PARP inhibitors, we get concerned about whether we're going to get the same response that we got before. The response to this drug actually appeared to be better in patients that have been exposed to PARP inhibitors. As you can imagine, this drug was coming onto the market shortly after a wave of multiple PARPs were approved, so this was very significant. And the toxicity was, not too bad. As you can see here, grade 3 and above was 8%. Dose delay occurred only in 32%, and dose reduction in 19%. And discontinuation was in less than 10% of the patients. So it was well tolerated. And as a result, it got approved by the FDA, granted expedited approval, but they mandated, of course, that we do a confirmatory trial, and that is this, the Mirasol trial led by Professor Katie Moore. And in that trial, we used the standard control arm, was actually similar to Aurelia without bevacizumab, so it was MAV single agent versus pegylated liposomal doxorubicin, topotecan, and of course, weekly paclitaxel. And this trial met its endpoints. As you can see here, the progression-free survival was, the hazard ratio for the Kaplan-Meier curve was 0.65, and the overall survival had a hazard ratio of 0.67. If you look at the right side, waterfall plots, you can see that the MAV drug had an overall response rate of over 40% compared to less than 20% in the chemotherapy-only arm. But what is significant about this trial is it was the first time that we demonstrated a statistically significant overall survival advantage in the platinum-resistant ovary cancer space. And there are so many, antibody drug conjugates that are being developed. And as you can see here, just look at the bottom of the slide, targeted towards TROP2, B7H4, cadherin-6, and mesothelin. And I have more slides of many more antibodies being developed. Antibody drug conjugates. The top three here are targeted against folate receptor alpha, just like the MAV drug. Then there's the one targeted against NaPi2b, cadherin-6, TROP2, mesothelin, as mentioned before. And these are the trials that are still, some of them are still running, and we're hoping that they will read out soon. These slides are available to you, of course. I'm not going to read all of them. And we further here especially define, trials that are going on based on the, the payload and the targeted antigen, which is listed on the left side of the column there. And the GOG, of course, as always, is in leadership role, is championing a lot of these trials, as you can see here. Many of the trials, now at the top there, you're going to see the Rosella trial, which is the relacorilant combined with, taxane in platinum-resistant ovary cancer. My very good friend, Professor Colombo, is going to be talking to you about that. And we have the ADC trials. So again, these are all, some of them are closed, and we are hopeful that they will read out soon so that we can know if we're going to have additional options for our patients. I think that's it. Thank you.
Great. Thank you, Alex. That was very informative. Thank you. Sort of tells us where we've been, right? And where we're going now with the ADCs. I think everyone's excited. But, we say we have ADC mania in endometrial cancer, a little bit in ovarian cancer, but we do have other things going on in ovarian cancer, which is, I think, equally exciting. I want to thank the sponsors of the symposium, Corcept, so thank you for sponsoring this. And we're going to hear now from Dr. Nicoletta Colombo, who's going to talk about evaluating new opportunities in ovarian cancer beyond the ADCs. Nicoletta?
Thank you. Thank you. Thank you very much, and thank you for being here so early. So I want to talk about new opportunities in patients with the so-called platinum-resistant ovarian cancer. We heard that this is not the right definition anymore. We prefer to say patients for whom platinum is not the best option. And you have heard a lot of trials ongoing, most of them with ADCs. But of course, there are other strategies which are currently under investigation for this population, and this represents, of course, a very high unmet need. So I want just to mention briefly some of them. For instance, I would like to start with the cell cycle regulation and DNA repair, which is an important target. Why? You see here the cell cycle, and as you know, when there is a damage of the DNA, the checkpoints, the cell cycle checkpoints are activated. Why? Because they have to arrest the cell cycle to allow for DNA repair, and so that we can have an appropriate DNA replication. There are several checkpoints. One of these is the WEE1, which is a key regulator of the intra-S and G2M cell cycle checkpoint. And as you know, most ovarian cancer have a p53 mutation. So the loss of p53 function, which is another checkpoint, and control the G1S cell cycle checkpoint increases dependence on the other checkpoint, the G2M. So if we use a WEE1 inhibition, we inhibit WEE1, and this will lead to dysregulation of the G2M checkpoint and eventually to mitotic catastrophe. A few years ago, this very interesting randomized phase 2 was reported. They use a WEE1 inhibitor, which is called adavosertib, together with gemcitabine versus gemcitabine. And these were patients with platinum-resistant and refractory ovarian cancer. And as you can see, the addition of this WEE1 inhibitor, adavosertib, to gemcitabine provided an improvement in both progression-free survival and overall survival. This is a randomized phase 2. Now, more recently, another WEE1 inhibitor have been investigated, and this is azenosertib. Here you see this drug was used together with different chemotherapies, leading to a response rate of about 40%. But the other day here at this conference, we heard a very interesting presentation with this drug in patients selected for cyclin E1 overexpression by immunohistochemistry. And by using azenosertib in this population, they demonstrated a response rate of 35%. So I think also this is a nice strategy to be considered and to be further explored for patients with platinum-resistant and even refractory ovarian cancer. What about immunotherapy? I mean, we had so much hope for immunotherapy in ovarian cancer. All the rationale was there. And we conducted so many trials for ovarian cancer, not only in platinum-resistant, but also in frontline and platinum-sensitive. And as you know, all of them were negative. So we were not able to demonstrate any advantage for the addition of immune checkpoint inhibitors to standard chemotherapy in ovarian cancer. So you may think that the game is over. But of course, immunotherapy is much more than just checkpoint inhibitors. And I think there are other strategies which may be interesting and worth it investigating. I just mentioned a few of them, but there are many others, including vaccines and cell therapies and so on, but these are the most advanced. This is a drug which is called nemvaleukin alpha, and is a novel engineered cytokine which was designed to selectively bind the intermediate affinity IL-2 receptor. And in this way, it can preferentially activate CD8 positive T cells, NK cells, and without expanding the Tregs. And in this way, also, you can mitigate toxicity. And the trial has been conducted and is ongoing, and so we will see if this will lead to positive data. The other drug I want just to mention is this drug, which is called ubamatamab, and is a human bispecific antibody designed to bridge MAC16 on cancer cells with the CD3 expressing T cells to facilitate T cell activation and cytotoxicity. Also, this drug is studied in a phase 2, and we'll see where we are going from there. But I want to talk now about another very interesting strategy that we can utilize in patients with platinum-resistant ovarian cancer. And this is the targeting of the glucocorticoid receptor. Why? Because cortisol contributes to chemotherapy resistance by suppressing apoptotic pathways that cytotoxic agents such as nab-paclitaxel utilize. So cortisol acts by binding to the receptor, the glucocorticoid receptor, which is expressed in ovarian tumors, and high glucocorticoid receptor expression is associated also with poor outcome. This drug is called relacorilant, is a selective GR modulator, and inhibits the anti-apoptotic effects of cortisol and enhances the efficacy of cytotoxic agents. We conducted a few years ago this randomized phase 2, and we included 178 patients to receive the control arm, which was weekly nab-paclitaxel, or 2 experimental arms. Relacorilant was given continuously together with nab-paclitaxel weekly, or intermittently. So it was given the day before, the day on, and the day after the administration of chemotherapy. And the primary endpoint of this study was progression-free survival. And as you know, this population was, I want to underline that this population was very, very heavily pretreated. We even included patients with platinum refractory disease. And you know, in the majority of trials, these patients are excluded. They are not included in any trial. So we also had platinum refractory disease. And the majority of patients had received taxane before. 50% had received bevacizumab, and also PARP inhibitor therapy in 30% of the population. So this was really a heavily pretreated population, I think much more than what you see in clinical trials in this setting. What about the safety of this compound? I mean, the major side effects are related to hematological toxicity. And then you see also some neuropathy and fatigue and asthenia. As you can see, they do not look to be higher in the, particularly in the intermittent administration of relacorilant compared to the comparator. But I have to say that all relacorilant treated patients receive prophylactic G-CSF to reduce the risk of neutropenia. And on the other hand, in the control arm, where the decision of using G-CSF was left to the investigator, 46.7% of patients receive G-CSF. Now, let's look now at the results. This was the primary endpoint, the progression-free survival. And I will focus on the intermittent arm because it was the one providing the best evidence of activity and also the best toxicity profile. And as you can see, by looking at progression-free survival, this is the overall population. So as I said, a heavily pretreated population, including platinum refractory disease. And you see there was an improvement in progression-free survival with a hazard ratio of 0.66. The median progression-free survival was 5.6 in the intermittent arm compared to 3.8, which is what we expect actually in this population. And also, while overall response rate was similar, duration of response was significantly improved in the intermittent versus the comparator arm with a hazard ratio of 0.36. And this is the overall population, the intention to treat population. Again, here is the overall survival, and as you can see, there is a clear trend for an improvement in overall survival by the use of intermittent relacorilant together with nab-paclitaxel, with a hazard ratio of 0.67, a median overall survival of 13.9 months versus 12 months, and 27% of patients in the intermittent arm were still alive at 24 months compared to 14% in the control arm. Here you see the overall survival in the subgroup, excluding patients with primary platinum refractory disease. And again, you see a clear trend for improvement in overall survival, even greater improvement with a hazard ratio of 0.63. So the median is 13.9 versus 12.2. So it's clear that a benefit is seen in this population. Now, if we look at the forest plot and different subgroups for overall survival, you see that the results were quite consistent. However, you may identify that the benefit looks greater in patients with only up to 3 prior lines of therapy, so excluding those with 4 prior lines of therapy. Also, the benefit was greater in patients who had received prior bevacizumab, and also, of course, in the population excluding primary platinum refractory disease. Now, last year at this conference, I updated the overall survival results. Here you see the end of study analysis for the overall survival in this group. And it is confirmed clearly the benefit in overall survival at this final analysis. And as you can see, at 24 months, we have 29% of patients alive in the relacorilant arm compared to 14% in the control. And at 36 months, we have 9.8% alive compared to 5.3%. So I think even with a very long follow-up, you can see confirm a clear benefit with the addition of intermittent relacorilant to nab-paclitaxel. And even more, what you see here is a subpopulation, and is the subpopulation with up to 3 prior lines of therapy, including prior bevacizumab and excluding primary platinum refractory disease. And here you see the benefit is even more clear, more evident. And the median OS was prolonged by 5 months in the intermittent relacorilant plus nab-paclitaxel versus nab-paclitaxel monotherapy. And this population is the one that we selected for the trials, the phase 3 trial, Rosella, which included exactly this type of population, so patients with up to 3 prior lines who had received prior bevacizumab and excluding platinum refractory disease. So here I come to my conclusion. I think this selective glucocorticoid receptor modulator, relacorilant, has shown potential in restoring chemosensitivity and enhancing chemotherapy efficacy. In a randomized open-label phase 2 study, intermittently closed relacorilant plus nab-paclitaxel improved progression-free survival, duration of response, and overall survival versus nab-paclitaxel monotherapy. And also with additional 16 months of follow-up, end of study analysis that I've just shown confirm finding from primary overall survival analysis. So you have seen intermittent relacorilant plus nab-paclitaxel improved overall survival versus nab-paclitaxel monotherapy with a hazard ratio of 0.69. This is with 38 months follow-up. Chance of survival at 24 months double for patients receiving relacorilant plus nab-paclitaxel versus nab-paclitaxel monotherapy. And in the subgroup of patients with 1 to 3 prior therapies, including prior bevacizumab, without primary platinum refractory disease, the median overall survival was prolonged by 5 months with the use of relacorilant plus nab-paclitaxel. And of course, as I said, these promising results have paved the way for the Rosella trial, which completed the accrual right now, and hopefully very soon we will see results. This is the Rosella trial, and as you can see, it's patients with, including 360 patients with high-grade serous, up to 3 prior lines, excluding platinum refractory, and with prior bevacizumab. And hopefully we will see positive data in the near future. Thank you very much.
And we're fortunate enough to have the PI of the Rosella trial sitting at the table here, Alex. So, Nicola, you showed the overall survival when you pull out the platinum refractory. I think it was 5+ months, 5.3 months, which is pretty impressive. Alex, you're not in the Rosella then allowing those patients, is that true? The platinum refractory?
Yes, the Rosella trial did not allow people with platinum refractory disease, just because of what Professor Colombo showed.
Right. Okay, great. All right, well, it gives me great pleasure to introduce our next speaker, talking about future directions in ovarian cancer care and engaging discussion, Dr. Lindsay Wilmot.
Thank you so much, everyone, and thank you for waking up nice and early. I apologize. I seem to have picked up an allergy here in Seattle.
Rain.
Maybe
You're allergic to rain.
I am allergic to rain. The desert has made me allergic to rain, but
yeah, that's why you live in Phoenix.
have been lucky enough to have been invited to talk about clinical trials and clinical trial considerations. I remember several years ago, I was watching a lecture about burnout in medicine, and the lecturer was really pointing out that you need to pick something that brings you a lot of joy and try to create that as a focus in your career. And for me, this is certainly clinical trials. So I think it's important to realize that though not all of us have the ability to open clinical trials at our sites, hopefully all of us have the ability to consider clinical trials for our patients. And that can sometimes mean referring patients to a place where clinical trials are open, or feeling free and excited to have dialogue with people who are either involved in the trials to see what is available for our patients. I think the lectures that we were lucky enough to just listen to really outlined that standard of care single agent cytotoxic chemotherapy really is not where it's at for our patients who are not candidates for future platinum-based chemo. So I wanted to highlight an example of a patient who was under my care and kind of her course through her therapy to just talk about where clinical trials can come into play. So this is a 62-year-old who had a history of a stage 3C high-grade serous ovarian cancer. She had very significant disease burden at the time of her presentation. And after counseling her that she probably was not a great candidate to consider an upfront debulking, we elected to initiate neoadjuvant chemotherapy. She decided to go on clinical trial first, which included treatment with carboplatin, paclitaxel, and bevacizumab, and she was subsequently randomized to receive either dostarlimab or placebo. She had an excellent response to that therapy and underwent an interval debulking to no gross residual. And then following that surgery, she completed her adjuvant chemotherapy and transitioned to maintenance. And on this particular trial, that included bevacizumab, dostarlimab versus placebo, plus niraparib maintenance. So this patient did very well, actually. She was without evidence of disease for 14 months following completion of her upfront cytotoxic chemotherapy, and then she was subsequently diagnosed with platinum-sensitive recurrence. So we discussed options and elected to continue the bevacizumab and reinitiate treatment with carboplatin and paclitaxel. She, again, did well on the regimen and had no evidence of disease, but unfortunately, 4 months after completing her cytotoxic chemotherapy, she had evidence of recurrence with a rising CA-125 and evidence of disease on scan. So I think that brings us to our first question. The patient was initially platinum sensitive, but what do we want to do when she becomes platinum resistant? There are a number of options to consider. Certainly we could do an Aurelia-like regimen, continuing non-platinum chemotherapy, plus or minus bevacizumab, understanding that obviously on the Aurelia trial, those patients who were treated with single-agent cytotoxic chemotherapy had very poor duration of response. Some providers might consider doing platinum-based chemotherapy, maybe something like cisplatin and gemcitabine, plus or minus bevacizumab. And then, of course, other approved agents, including mirvetuximab, or consideration for clinical trial. So I was hoping we could get some dialogue going. I know it's early, and maybe no one is quite ready to stand up and talk. But is there anyone in this room that would consider one of these regimens, and is there any particular reason why you would consider it? Maybe I'll throw it out to my panel members.
So you're talking about platinum resistant or platinum not the best option.
Correct.
In this population, I rarely use platinum, of course, and first of all, my choice will be clinical trial. If I have a good clinical trial, promising clinical trial, that would be my first choice. Otherwise, of course, I will test for folate receptor alpha, and if she's positive, I will give her mirvetuximab. This is what we usually do. In the past, for these patients, only weekly paclitaxel was the best option, but now we have both clinical trial and also mirvetuximab available.
I agree with that. My first will be clinical trials, and If there is none, and I do not have a test that allows me to use folate receptor, drug, I would put on weekly Taxol with bevacizumab.
Okay.
Boring, but I agree. I would do clinical trial first, but the MERV, obviously, the testing's the key. You have to, be above 75%, and I think for folate receptor alpha, and that's something we need to be building into our mindset of getting that information. So you have to be thinking about how you're doing that in your practice. When are you getting that information? Some people send out to the big labs, and you get that, whenever you do. But if you're not, you need to be thinking about how you're going to acquire that information.
Is anybody using platinum in this situation?
For me, I wouldn't here because she's just 4 months out and just had 2 rounds of platinum relatively close. So I think that I'd probably try some of these other ones first, and if she's a responder phenotype, I'd consider going back to it. I'd love to hear what others do.
And we don't know if she received also PARP inhibitor or not. If she was randomized, do you know, in frontline? She received also, she was in first, no?
Yes.
Yeah.
So what was your question?
No, the question is whether she received also PARP inhibitors as maintenance.
Did she receive a PARP
Yeah.
inhibitor as maintenance?
Yeah.
Yes, she was on niraparib.
Yeah.
But I do think it's a great question,
No, related to the use of platinum.
Yeah, no, absolutely. I am curious about testing in this room. Is everyone testing at time of diagnosis? Can we see a show of hands for who would do somatic testing at that time?
A few people, yeah.
What about time of recurrence? Are some people not doing any somatic testing at all? So for folate receptor alpha, it does appear to be pretty stable over time. Based on some prior retrospective analyses of pathologic studies, it doesn't really seem that folate receptor alpha changes much with prior therapy. So it might not be, for that particular marker, the most important thing to consider rebiopsy and retesting. But in my practice, I personally do somatic and germline testing at time of diagnosis, because I think it helps me personally to lay out a little bit of a roadmap about what we might do in any given situation.
I was also going to mention that based on the Destiny pan-tumor trial, I would test the tissue for HER2 expression as well, so that I might have an opportunity to use the trastuzumab deruxtecan drug if she was to be positive. But yes, I agree with you. I do test for germline mutation and also tissue-based mutation at the time of diagnosis. I usually put it, if the patient is getting neoadjuvant chemotherapy, I typically roll that into the second cycle of chemo, because they are overloaded with information at the beginning, and so when they come for that second chemotherapy is when I discuss testing and then get the test done. So by the time you're doing the surgery and they're coming off chemotherapy after surgery, the result is ready and you can use it.
Yeah, if I may, I want to stress the importance of doing the test at the time of diagnosis, even when you are choosing neoadjuvant chemotherapy. We did actually 20 patients. We compare the HRD test before and after neoadjuvant chemotherapy, and as you may expect, it can be different for several reasons. I think one, because maybe with chemo you are selecting, of course, the HRD negative population, and you get rid of the HRD positive, or because sometimes after neoadjuvant chemo, you have less tumor, and so the representation of the tumor is not as good as at the beginning. So I think it's very important to obtain this information at the time of the initial diagnosis. Again, not wait until after neoadjuvant chemo. It's important to do it, to collect enough tumor to do the test before neoadjuvant chemo. That's something I want to stress, because we did this comparison and we found out these results. So
All right, excellent.
Lindsay, can I just ask,
Oh,
by
yes.
show of hands, how many people are getting this information up front, right at diagnosis? All the things we're talking about, folate receptor, most of you, yeah. Okay.
All right. So this patient was in fact folate receptor alpha upregulated, and her HER2 status was negative. So the patient then began mirvetuximab soravtansine, and she received 7 cycles of therapy, but showed evidence of disease progression, again with a rising CA-125 and evidence of disease progression on imaging. So now what are we going to do? We've kind of put up the same options here. Is there anyone who would consider, as Tom suggested, maybe now that she's had a little break from platinum, considering re-challenging with platinum at this time? Okay. Obviously, platinum resistance is on a spectrum, and so some patients may actually respond to platinum again in the future, even if they had, had a prior recurrence within that 6-month window. But I think this is an excellent time to really consider clinical trial for this patient. And that's certainly what I would talk to her about. Any differing opinions up here with my colleagues?
No, I mean, most of the time you are going to, if there are no clinical trials like Rosella and any of the ADC trials, you generally would go back to one of the other chemotherapy agents that she hasn't used. In the United States, I know that the philosophy of usage of BEV is a little different in Europe, as Professor Colombo can explain, but here we reuse BEV all the time. So I would just, based on what she has been exposed to, I would choose one of those chemotherapy options, but continue that with BEV. There's like another drug that can be an option there, which is oral Cytoxan, metronomic dose, cyclophosphamide with bevacizumab is another option that you can consider.
Okay.
Yeah, we would love to use bevacizumab after bevacizumab. Actually, we performed a study showing that, it can be effective when you re-challenge with bevacizumab, but unfortunately we have some regulatory issue which prevent us from that. Yeah. But now that is biosimilar, we tend to use it more and more, and I do agree with you that bevacizumab is always a very good option. The other thing I want to say about re-challenge with platinum is that we recently published on Gynecologic Oncology a retrospective experience for patients so-called platinum resistant, that after multiple lines of therapy, we treated again with platinum, and surprisingly, we achieve a very high response. 30 to 40% response rate. So platinum should always be considered, I think, when maybe you have used a lot of other agents, and in terms of re-challenge, is one of the best drug to re-challenge for me.
Well, Lindsay, you didn't say, so what would you do? Would you re-challenge with platinum?
So I think that this is a great time to consider, how many lines of therapy has she had? Because once we start to get to too many lines of therapy, as we just discussed, patients may become ineligible for clinical trial or may become much less likely to respond to future therapy. So I definitely think that I keep that in the back of my mind. And if I have a clinical trial that is available, I think that this would be an excellent time to consider it. But in the absence of an applicable clinical trial and no other target options based on her somatic profiling, I would consider re-challenging with cytotoxic chemotherapy, and certainly I would consider platinum to be one of those agents that I might use. But this patient was counseled regarding clinical trial opportunities, and she opted to enroll in Rosella. So obviously there are some important considerations for clinical trial. The first is, performance status. I think really one of the most important components of when we're treating our patients in general. We want to make sure that they're healthy enough to tolerate therapy, and certainly performance status is a very important parameter that's assessed in clinical trial eligibility. So we don't want to be enrolling our sickest patients onto clinical trial because those patients are unfortunately at baseline more likely to have poorer outcomes, and they certainly could theoretically skew the results of some of these clinical trials. So we want patients who are functional to be considered. Obviously, there are also some other lifestyle or understanding considerations. So for this particular medication, it is an oral regimen. So is this someone who can be compliant with an oral regimen? Something we're not watching them do at home or just doing pill counts when they come in for their visits. And then other concomitant issues, including other medical issues. So for relacorilant, we do not recommend patients who have to be on chronic corticosteroids to use this medication because it may have an impact on some of the functionality of the drug. So for patients who require chronic corticosteroid therapy, they may not be the best candidates for this particular trial, or other medications that they potentially could be on that could influence the kind of bioavailability or change the amount of drug in the system, which could certainly worsen toxicity, for example, CYP3A inhibitors or inducers. So I'm curious, in terms of clinical trial accessibility for the people in this room, does everyone feel like they have the ability to consider clinical trial, or is that something that's challenging in your neck of the woods? Like, if you wanted a patient to be considered for clinical trial, by show of hands, how many people do you think would be able to consider enrolling a patient? Okay. Do you have the ability to get patients to other centers for consultation if you wanted to have that opportunity? Because I think this is something that certainly Tom is passionate about, trying to increase accessibility of clinical trial to all of our patients. And I think it's an important dialogue that we need to have about how we can make that more reachable for more patients to be able to have at least a conversation about what trials they may be a candidate for, and then how we can assist them to be able to enroll and be able to come in for their therapy.
Yeah, one of the things we've done through the GOG Partners Program and the foundation as a whole is look at this concept of the accrual culture. And so we put together some videos and so forth. So encourage you to go on our website and look at some of those. And I think we're going to sort of reinvigorate that and try to get some great ideas. So if you have any ideas of how to best get people on the trials, let us know. But obviously, you have to be thinking about them. You have to know, and you have to have a trial open or a trial that is in the area that you can get patients to. But I think it's incredibly important. It's how we make progress. We can't talk about new data if we don't have any trials. So this is what's exciting.
One of the most important trials to me that I use to counsel patients is a very big meta-analysis that was done by the Harvard institutions many years ago, which actually compared disease for disease, patients that were treated on clinical trials versus patients that were treated on standard of care. And every time, regardless of the disease site, the patients that had treatment on clinical trials did better. They had longer PFS overall, they lived longer.
Yeah.
So whenever a trial is or trials are available, you really should encourage your patients to participate on clinical trials.
Well, especially in this setting, right?
Exactly.
I mean, there's just no...
I wanted to say exactly the same. I mean, when you are in a situation where platinum is not the best option, I think you have to tell your patients that the probability of response to standard of care chemo are so low. So, it's so important to consider clinical trial. And maybe different if you are, in a frontline setting where you have very effective regimens or even a platinum-sensitive relapse. But when you have a platinum-resistant population, then, you have to be very clear, response rates are very low. And so it's better to consider a clinical trial if you have one.
Nicoletta, in the United States, the percentage of patients that go on to clinical trials who have ovarian cancer is alarmingly low. It's in the single digits.
Really?
Yeah.
Yeah.
Wow.
Under 10%.
Yeah.
Some as low as 4%, depending on the cancer. What's that look like in Italy?
Yeah. Well, in Italy, you know, patients are actually, we don't have a referral from doctors, but we have self-referral from patients. I mean, many patients come to our institute, which is a referral center, of course, because they want a clinical trial. They want a new drug. They want, because they know that their, you know, chances of cure are very low, so they are traveling from the south of Italy, they come to Milan because they want a clinical trial. It's completely, I mean, these patients are motivated. Not all of them, of course. Many will stay at home because they are not motivated, but there is a huge search for new drugs, I must say, among our population. So it's completely different compared to what you are saying in the United States, probably. Patients are, you know, are looking for the miracle, for the wonder drug which can, you know, solve the situation, of course.
I also, just to say, you know, I can speak, hey, thanks, Lacey.
Thank you.
From the experience from England, that most Western European countries, the structure of cancer care, it's very, very different from the US, because in Western Europe, a lot of cancer care is regionally centralized. Many of the countries have, you know, you have a major cancer treatment center in each region, and most people being treated for cancer are going to go to that place. That really makes it easy to recruit patients to clinical trials, because those centers have a lot of trials open, and the patients are going to come there. In the US, if we're going to boost trial participation, it requires patients who are being treated in places without clinical trials to have doctors who are willing to, you know, look around and refer them to places where there are clinical trials, and that kind of becomes challenging, both logistically and from business point of view.
Well, Lindsay, first of all, thank you for a great case presentation and a great discussion. Thank you. And we've now transitioned into where we were talking throughout, which was what I was hoping for, but anyone from the audience too. We have a microphone and a microphone, or just get up and yell. We'll pick you up. But we'd love to hear from you, what you think, and any questions for the audience. If you have any, just stand up. In the meantime, we'll keep babbling on up here, because we're good at that. So, Lindsay, what do you think about this region of the world where, I mean, I don't want to paint this with too broad of a stroke, but I think it's very interesting how some countries are able to do much better in terms of, and Alex brings up a good point, sometimes it's the system. I do think counseling is a big part of it, though. I think our U.S. physicians, we've done a wonderful job of thinking about patient autonomy and thinking about shared decision making and a lot of the other buzzwords that we use around this. But when it comes to clinical trials, I don't think people perhaps advocate strongly enough. They say, well, it's an option, and then they throw it out there, and the patient's like, I don't know what to do. What am I supposed to do? And then we say, oh, well, why don't you go talk to one of our clinical trial coordinators? And the first thing a clinical trial coordinator does is start going over all the possible adverse events that can happen in a clinical trial. And I mean, it's not a very positive experience if you think about how we do this. So it's always struck me as a very strange construct that we use in this country to try to get people on the clinical trials. And it's usually a highly motivated patient that has to go through these hoops to do that. And I think that's unfortunate. I think we need to do a better job, but obviously we need, you know, full disclosure and counseling and all. I'm not saying we don't do that, but when you start with all the adverse events and the physician goes, well, it's an option here, you can go talk to this person and prolong your visit here, and it's just, I don't know what you think.
No, I think that a lot of perhaps the low number and the reluctance to enroll is related to the assumptions that some providers may make about patient desire to consider clinical trials. So sometimes you'll just, you know, be like, oh, this person would probably never want to go on trial. I won't even mention it.
Yeah.
And so there is a really great initiative called Just Ask which is talking about, just ask, is this something that you would be interested in? I can give you more information. The other thing I think is important is, and it's not a small thing, when you talk about clinical trials, this is a very long discussion. It's adding time to a very busy clinic day, which is something that is challenging for very busy practitioners. So certainly it is an extra burden added to our very busy clinical schedule. And so I think we need to kind of consider how we can help ease that burden for providers so that they have more time to be able to have these sometimes very complicated conversations. I will say in terms of access, the sponsors of these trials are to be commended, in my opinion, because they are recognizing that access in transportation, sometimes something as simple as getting to and from a visit can be challenging for some patients for cost. And there can be some support services that are available to help patients to be able to get to and from the office. And also really having a very supportive clinical trial committee and community at your sites or in your city. So I know there are a lot of outreach programs in some cities where maybe there are big academic centers where clinical trials are open and smaller community practice was where they are not. And they try to have quarterly dinners to have a lecture and a conversation about what trials are open and how patients can get into those sites so they can be seen for consideration. I think those are all some really great opportunities, but there are some hurdles I think that we need to figure out how we can address them.
Yeah, I think that's a really good point. I think also, the loss of physician autonomy in many systems, whether it's private practice or in academia now, with really being measured, your values measured only by RVUs, how many RVUs you generate, tying that to productivity as how many patients can you churn, really goes against what we're talking about, right? Good counseling, thinking about that. The Just Ask is an amazing program. We've known that, bringing in social determinants of health and looking at some of our underrepresented populations really suffer from bias of who would be a good candidate to go on a clinical trial. And largely, that's been a very wrong judgment in the sense that you find that patients are very interested, and we need to do a better job of not prejudging who wants to go on the trial, and everyone should be invited to have the same counseling, in my opinion, with some exceptions, obviously. But, I think that, we also see what's going on with venture capital buying practices, and it's even going to reinforce more about the return on investment rather than how many patients are going on trial, good quality care, which takes time, right? And that's the biggest challenge that we have. So.
Yeah, then the other thing we are doing, for instance, we send over a kind of newsletter to our network. We have small centers or small hospitals. Sometimes they refer patients. So we send them a newsletter with all the trials which are active. And this usually is quite helpful because then they can recognize when they have a patient. And of course, we have a dedicated email that they can send the information for the patient so that, it's easy because, again, these people are very, every day you're so busy in your clinical practice and you don't want to spend time to try to call someone and so on. So you have an email, you send email with the information and then we'll answer. So this is another way to increase, I think, accessibility. And in terms of patient communication, to go back to this issue, I think one of the, I don't know for you, but for me, one of the most difficult is to explain the randomization. And they feel like, oh no, I want the drug, I don't want to be randomized, no? And the concept of randomization for some of them is really, how do you solve that? Do you have any specific tip for?
I know. No, it's a great question. And I usually just say it like it is. We believe from either preclinical work or early clinical trials that this medication is going to be beneficial, but we just don't know yet. And so we have to design this trial to really understand the answer to that question And so that is why there is a chance you may not be randomized to the study drug. You know, I know it's disappointing. Patients are disappointed when they are randomized to the standard of care arm. And I think for some trials, especially trials that, you know, may randomize to a drug versus placebo, it can become particularly challenging.
Yep.
You know, for example, maintenance trials to get patients to enroll. But yeah, that is a great question. What are other people's ways?
I was just going to say that that problem, I think, is a uniform problem, Nicoletta, for all of us. But I think it's more important in phase 1 and phase 2 trials, where you're really, you know, beginning to study the drug or develop the drug, and you're not comparing the drug to a standard of care. In phase 3, I think I have less problem with explaining randomization, because I tell the patients, see, as you're sitting with me here, if you say you don't want to participate in a clinical trial, there is a set of options that I'm going to give you to choose from. If you go on this trial, you're going to still receive one of those options. There's no problem with that. You're going to get a standard of care minimum. What you may not get is whatever it is that this trial is studying. And so you're losing nothing by going on the trial. You're either going to get standard, which you'll be getting anyway, or you're going to get a standard compared to, you know, compared to this new drug. I think in phase 3s, like the Mirasol study, I participated in that study. It was very easy because you have the phase 2 to point to say, like, we had a good result in phase 2. I can't promise you that result, but we're hopeful that we're going to get the same thing in this confirmatory trial.
What I say, if I may, I have another way of saying, you know, when they say, no, but I would like to have the drug, the new drug, and I say, okay, listen to me. If you enter the clinical trial, you will have 50% possibility to get. If you don't participate in clinical trial, you have 0% possibility to get the drug.
Yep.
And that is very convincing usually. They buy that.
That's right. That's right. Alex, you're the PI for Rosella. I know you can't tell us anything about the data unless you want to and violate all your confidentiality agreements, but no, I don't want you to do that. Then I get in trouble. But what would, you know, in terms of, you know, just in your own practice, how have you seen patients tolerate
the Rosella? I actually, so this is interesting, because when the phase 2 trial that Professor Colombo led, we participated in that trial. And when Rosella opened, after, of course, long after the phase 2 had closed, about 2 of my colleagues, I have about 10, actually 11 practice partners, they came and said, Alex, that drug, is that the one that is in this Rosella study? I said, that's the drug. It's like, oh, I love that drug. I want to put my patients on it. When Rosella, fortunately, I don't want to say unfortunately, enrolled very rapidly and closed, the day that I let the faculty know that Rosella had closed, I got at least 4 calls. There were about 3 attendings who were lining up patients for it the very next week. So the thing about this drug, relacorilant, which is really exciting, is it's a very, very different mechanism, right? Like, unlike anything that we've ever used in cancer. I mean, think about it. When I was in residency or fellowship, you know, steroids we gave like water to patients being treated for cancer, either treating side effects, or if you go to lymphoma, huge doses of steroids. It's part of what they give them in the MOP regimen or COP, whichever regimen that you're using. Yeah. And then to now see that a drug that antagonizes steroid can make a patient being treated for ovarian cancer live longer, that's huge. And I think that very, very sharply different mechanism, it's going to make this drug very interesting when the result, and no, I do not know the result of the Rosella trial, when the result is read out, which we're hoping will be positive.
Yeah.
And can you maybe just explain how you came up with the control arm of nab-paclitaxel instead of just paclitaxel? What's the rationale for that, maybe?
Well, the rationale for that is because of the mechanism of action of the drug, right? It antagonizes glucocorticoid receptors. So basically, it's like you don't want to be trying to put out fire and you're using gasoline to do it, right? So that's the point. You want to make sure that you're not giving steroid in a situation where you're actually modulating steroid receptors in order to get your...
So with the NAB, you're
action.
able to avoid
The
steroid
NAB,
pre-medication
right. The
that
nab-paclitaxel
you have to use for weekly paclitaxel.
does not require
Yep.
steroid.
Right.
Yeah.
Okay, any other thoughts or questions from the audience or panel? Any final comments at all? All right, well, we'll wrap things up. Do remember that this is an accredited program, and you get up to 1.25 CME credits here. You have to do a few things, though. You have to fill out the pre-test, which you can still do. You have to fill out the post-test, which we'll need you to do, and you need to do the post-meeting evaluation as well. There's a QR code here again and on your table if you haven't gotten that, so you can complete both the pre and the post-test there. Online evaluation will come to you by email, and you claim your CME credit through the GOG. You must complete the evaluation. Certificates will be mailed within about 5 weeks, and your feedback on that evaluation is very helpful. That's how we get better, so we really appreciate anything you can share with us that would be constructive criticism, so thank you. The session will be available on demand, so you can go to our website at www.gog.org for more details if you wish to watch the program again. So thank you to our great panel. I want to thank our commercial supporter, Corcept, on behalf of GOG Foundation. Thanks to all of you. And Lindsay, Nicoletta, Alex, thanks for doing such a wonderful job and really appreciate it. Hopefully this was a good way to wake up and enjoy your day at the SGO. Thank you.